Okay, let's just jump into some questions that anybody has. And normally I'd take the chair's prerogative and ask them myself, but this isn't my show, it's yours. So somebody's got a question, and if you want to direct it to any one of the individuals, that'd probably be best. We have a microphone over here. There's somebody. We got a runner? Somebody on, thank you, John. Somebody on roller skates here.
Dr. Shaw, have you found that when you use the non-invasive ventilation, that it makes a difference if you're using one with a rate versus one that just has the pressures?
Sorry, I didn't quite get that.
For the non-invasive ventilation,
Yes.
some of them just give the bilateral pressures and others at a rate, and I wondered if it's made a difference.
Is it a question of how much pressure? Or?
No, it's a difference of whether a rate.
Yeah.
Oh, okay, rate versus pressure.
A rate with pressure versus just the pressures.
A backup rate is what you're talking about.
Do you want me to take that?
Yes.
Yeah. So this actually ends up a little bit more in the sleep realm. So I'm going to jump in. I know that you asked Dr. Shaw. It's very important to remember that as you get into dream sleep or REM sleep, every muscle in your body becomes paralyzed except for your diaphragm. So anyone who is using accessory muscles to assist in breathing will lose that as they get into REM sleep, and you will not be able to trigger the non-invasive ventilator. It is fundamental that that backup rate be there. If a device doesn't have a backup rate, it is only for obstructive sleep apnea and should never be used for a patient with ALS.
Question in the back, John.
Hello. With the diaphragmatic pacer, we hear that insurance will pay for the anesthesiologist and things like that, but we're not hearing that it'll pay for the pacer itself. So I want to hear from the experts what you have found and how you have, do we have insurance companies paying for it? Thank you.
So I have to say this is only secondhand because we have not been putting them in clinically, but I've been told by Synapse that they've received insurance coverage from many different insurers, so it is being covered by some.
Hello. You're saying that with diaphragmatic pacing that it's improving neurotransmitter and the diaphragm is becoming stronger with that use of the diaphragm. Has inspiratory muscle training ever been tried with this disease? I've not read anything.
I know of one small trial with inspiratory muscle training in ALS that showed some benefit.
The one thing I would say is that those trophic factors that you're talking about that are elaborated with electricity, those are not going to be elaborated with inspiratory training alone if there's damage to that nerve and the nerve can't provide the electricity. So there is sort of a limitation there.
Hello, Mary Masry, physical therapist, and thank you, panel. That was great. You guys had barely any time, and it was so informative, so thank you so much. I just got back from Australia, where I was able to see the new Cough Assist machine. I am so excited about it. So I just wanted to let everyone know here. I don't know when it will be in the U.S., but it's been completely revamped and will be much more user-friendly. I compare it to, and I don't work for the company. I'm just a physical therapist that uses the product. It would be comparable to me to thinking of the old cell phones and now an iPhone. you're going to throw away the old cough assist machine and be ecstatic. So wherever Phillips is, shout out to you.
Hi, this is a question for Dr. Wolf. Is there any problem with syncing the functions of several of these different things together? Is there a problem with one overriding the other or getting things messed up, or how can they be used together?
Well, actually, in Dr. Litzon's slide, there was one little line there, which I think I'm probably the only one that picked up on. But when you integrate a diaphragm pacer with NIV, you have to make sure that the backup rate on the pacer is higher than the backup rate on the NIV. That way, the NIV is a slave to the pacer, and things won't interact and fight with each other.
I think part of that question, though, was is there a particular order you'd use your airway clearance devices in?
Oh, airway clearance devices. Oh, yeah. So what we recommend is that we look at the individual patient and tailor which choices they have for care based on the predominance of their disease. If you have someone that comes to you with a large secretion burden, say due to COPD, they're going to need a vest very early on. Whereas if you have someone who has no secretions, no bulbar disease, they may do very well with an ambu bag and nothing else. And so the importance there is that you try to make a decision at the bedside. There is no perfect answer, and that's why the French data that I showed you was not able to say that any one method was statistically better than any other. You just have to try them all.
I'll throw in my 2 cents. There's no data to support it, but the rationale for the vest is that it loosens secretions that are in the smaller airways and moves them to bigger airways that it's easier to cough out. But if somebody's cough is weak, you would still need something like the cough assist. So there are a lot of patients who will use the vest followed by the cough assist. Sometimes insurance coverage can be a challenge, but again, it winds up being an individual decision.
Hi. Can you speak to the use of oxygen with ALS, because we're getting some controversy around its use? Some clinics are saying go ahead, use a small amount. Others are saying don't ever use it at all.
It's a tough question to answer briefly. Most patients with ALS, as long as they have healthy lungs otherwise, don't need oxygen. So generally it's not much of an issue, and a lot of times people's knee-jerk reaction is to say, oh, somebody's short of breath, let's give them oxygen. So that's usually not the answer. It's a little bit controversial, but there's also some risk that giving somebody oxygen whose nervous system is blunted to how they breathe and has a tendency not to breathe enough, giving them oxygen could worsen that further. So in general, a good rule of thumb is if they're not using non-invasive ventilation, they shouldn't be on oxygen alone. If they're using non-invasive ventilation and for some reason still need oxygen, and that's a very small group of patients, but in those cases it's okay.
Pam, is the practice in England any different than that?
Hi.
I think you're hearing consensus that oxygen's not something you want to jump into. Certainly not the first thing.
My question is for Dr. Wolf. You mentioned the chlorhexidine, that the toothpaste is only available to hospitals, but then you also mentioned mouth rinse.
Yeah.
Is that available outside of the hospital?
Yeah, that you need a prescription for your doctor, but it is absolutely available.
Okay, great, thank you.
Yeah, it's just chlorhexidine mouthwash, and it's sometimes called, I just said it when I was up there.
Can I just add
Paradex.
that?
It's Paradex.
Paradex. Can I just add that my wife's a veterinarian, and the chicken toothpaste don't taste that bad, actually.
The study that was done with Cleveland and Michigan patients, was there like a 1-year follow-up? Like, were there controls to see if they were breathing any different than the patients who did not have the diaphragm pacing?
So the study that I showed from 50-some patients in Cleveland and Detroit was just looking at perioperative safety. There have been several studies looking at the longer-term effects, not in exactly that same patient population. Some of that is what I showed with the survival differences. But again, no real good prospective controlled studies comparing them, patients with diaphragm pacing to those without.
My question is, I'm not sure if I understood this correctly or not. Is the TASCA 500 ear probe thing comparable to the arterial blood gas test? And if so, why would one choose one versus the other in a hospital setting?
I think it's comparable to arterialized, so you can make blood in the small vessels, the capillaries, behave like arterial blood if you warm the earlobe for a period of time. But to take a sample still involves a jab and a prick to the ear and then squeezing the ear to get the blood out of it. So apart from a couple of outliers, in general, you get a result that correlates very well. So we use it routinely in our clinics as the patients are having their breathing muscles tested, and it seems to work very well.
The biggest issue also is availability of the device, and that's the thing that limits us from using it the most.
A question for Dr. Wolf. Doctor, I'm using the AmbuBag, and I feel all the good sensations that you described. But once in a while, I actually take myself to where I feel a little lightheaded and dizzy. What am I doing wrong?
Yeah, so when carbon dioxide drops too quickly, that's when you get that feeling. So if that happens, then you should do a few less coughs per session. And then maybe instead of doing, say, 5 coughs twice a day, you could do 3 coughs 3 times a day so that you don't blow your CO2 down too much.
There's a question in the back.
Yeah, with the diaphragm pacing, since the purpose is to build up the diaphragm muscle, why is it generally recommended that ALS patients not exercise to build up other muscles?
So patients ask that a lot. Should I, pump iron in the gym to try and build up the strength of weakened muscles? And my response is that as a limb is becoming weak, some of the motor neurons that supply that, the muscles in that limb have died off, and the surviving ones are able to sprout their axons and take over the muscle fibers that have lost their motor neuron supply. So the motor neurons that remain healthy are probably doing 3 or 4 times their normal workload anyway. And if on top of that you go and push them and exercise the muscle, I think you're probably overstraining the system a little. So my feeling is that gentle exercise is good, as we heard before, stretching, making sure your joints don't stiffen up, but actually using weights or really trying to build up a weakened muscle, I think is probably overstressing the system. Bob, what do you think?
Yeah, I agree with Pam that certainly what's left is already working twice as hard or 3 times as hard as it would. And there's a difference between stimulating the muscle directly, like the diaphragm pacer does, and having you try to turn them on and use your own anterior horn cells. There's old data from nerve injuries where you can stimulate the muscle directly and that will slow down muscle atrophy in a nerve which has been, say, damaged through trauma or something like that. In that particular instance, you're expecting the nerve to regrow and reinnervate that muscle, so you're not going to create excessive harm in that situation. In an ALS situation, until we can preserve motor neurons, you know, you're probably putting, by doing the exercise yourself, you're probably trying to put an extra stress on those remaining motor neurons.
Pamela mentioned as one of the symptoms of ALS being difficulty laying flat. I would like to ask her to explain why this is so. Also, I would appreciate if someone said something about the difference between ALS and PLS. We have only talked about ALS, but
About PLS,
are there specific differences that regard what you have been talking about?
So those are good questions. I think the reason for orthopnea or this difficulty in breathing when you lie down flat is really gravity. When you're sitting up, your liver and stomach and abdominal organs are pulled down by gravity, and the diaphragm is freer to move. When you lie down flat, your liver and stomach push the diaphragm up into the chest so that the work of the diaphragm moving up and down is increased. So it's really a gravitational effect. I don't know if you want to add anything, Lisa.
It's another one of those physics things that we can't repeal the laws of.
Yeah. And in terms of PLS versus ALS, I think in PLS it is mainly the upper motor neurons in the motor cortex that are causing the problem. And there are some interesting differences. So a patient with PLS can have difficulty with their speech, but their swallowing remains really good for a long, long time. So you'll find patients who have speech problems, but they're still eating a normal diet. So there's something about the lower motor neuron component to swallowing in ALS that makes a difference. I think in PLS, so in relation to breathing, often patients with PLS don't need non-invasive respiratory support for a long time. So their breathing may be incoordinate because of the upper motor neuron damage. So many times patients with PLS will have poor forced vital capacity, poor respiratory function tests, because they find it difficult to blow out strongly to order. But when you check their blood gases and so on, they don't have a problem quite often. So you can get a false impression of the strength of the breathing muscles from that upper motor neuron component. But because their lower motor neurons are healthy or are healthy for a long time, the phrenic nerve motor neurons in the top of the spinal cord remain innervating the diaphragm. So the diaphragm muscle doesn't lose its nerve supply in the same way as in an ALS patient. So sometimes PLS patients do need respiratory assistance, but they can often manage for a long time without that.
Can I just add something about terminology? Because I was conscious when I was speaking that I was flitting between ALS and MND. MND is something that we use in Britain and a lot of the Commonwealth countries, motor neuron disease, and it's a bit of an umbrella term because there are a number of conditions come under that umbrella. PLS is one, another one called progressive muscular atrophy, which is predominantly a lower motor neuron disease, the nerves going out to contact the muscles. But by far the largest subtype of motor neuron disease, which accounts for about 90% of cases, is ALS. So the terms ALS and MND are used interchangeably, and over the next week they certainly will be several thousand times.
I'd also comment that, or I'll ask Noah or Lisa to comment about the effects of PLS on the flow volume loop. You can almost make that diagnosis just looking at the way they do their forced vital capacity.
Yeah, there's there's so much stiffness in the upper airway that dilating the upper airway to do a forced expiratory maneuver is very difficult. So that strong up peak that you would normally see is abolished, and instead the flow volume loop, or the output from the forced vital capacity, it's very squared off or rectangular shaped. And sometimes just looking at that rectangle, you know what's going on.
Yes, I'd like to ask the experts. I'm a Veterans Benefits Counselor with the Paralyzed Veterans of America. And my question is, some of the symptoms that I was seeing during this session are similar to those of a person with sleep apnea when we talk about things as respiratory issues with those with ALS. Because of that, I wanted to know is once a person is at that level where the respiratory dysphasia, things of this nature comes about, is that a level where you can consider that patient in need of aid and attendance? Because of that, the residuals of what the government base benefits on sometimes as the condition has worsened. And this is basically why I'm asking that question. In most cases, would it be considered that that patient is in need of some type of aid and attendance?
Oh, aid and attendance? Right. You mean personal assistance?
Well, yes. If he's at a level where the respiratory is at a level where it's using...
Aid and attendance is a term of art that the Veterans Administration uses.
Right.
Yeah.
For any time that they're using those devices, would that normally be a need for that type of assistance?
Yes.
Okay.
I'd like to quickly revisit the use of oxygen. Purely for someone who would be at altitude, a city like Denver or Salt Lake City. In that instance, what would you advise?
So the question is, if somebody's up at altitude, say the Mile High City of Denver in this country, or Salt Lake City, which is also at altitude of, 4,000 feet or so. So the question is, what happens to the respiratory mechanics at that point?
Sure. So as I had said earlier, most patients with ALS, assuming they have healthy lungs, don't need oxygen. Whenever anybody is at altitude, like it comes up most frequently when people are flying, but if somebody lives in Denver or other areas, their oxygen level will be lower. So if you're starting with somebody who has some impairment in their breathing, so they hypoventilate a little bit, they may need oxygen when at altitude. The easiest thing, so there used to be a lot of calculations that people would do based on what their lung function was, what their saturations were at sea level. The easiest thing now that pulse oximeters are so inexpensive is just to get a pulse oximeter and check and see what the oxygen level is at altitude and see if you actually do need oxygen.
I think we're going to have to cut off the questions here now. It's been an exciting session. I want to thank all the speakers. I want to thank the Les Turner Association, the Alliance, for everybody. And for those of you who stuck it out to the bitter end, thank you very much.